be your first step to protect yourselves from liability of medical legal trauma? What to do next? How to store the records? How long to store the records? When can you be called into the court of law? How would you depose as a witness or an expert? And finally, a checklist. Okay, so historically in literature it's been around, but probably one good landmark article is more than 200 years old now, in 1900s from the US, and then there are other more closer to home, Egypt, and then in India as well. So I've based some of this on the larger studies only in terms of the clinical profile of both rural and urban medical legal trauma in our context. So males are unfortunately 75%, and that's because almost all the cases are associated with some sort of an assault or injury, but the mean age can be as pediatric to about 75. And fortunately, it's only bilateral in 15%, 85% you're still dealing with one eye. The most common injury, at least from a legal perspective, is still a closed globe injury, but out of the open globe injury, penetrating eye trauma is most common. As you can see from a study from rural North India, farmers and laborers constitute to more than 70% of cases, and males can go up as high as 90%+. In rural areas, you are more likely to see trauma cases in the district hospital. They don't come directly to the ophthalmologist. But if you're practicing in a city or a tier 2 town, from literature at least, you're more likely to be seeing this patient first, even if it's a case of polytrauma. And so that's really important because you might be facing these situations. 90% of cases that eventually reach you with ocular trauma will require surgery. And over 90% of those who require surgery will eventually have legal blindness. So you can already see this is catapulting towards medical legal issues. If you're working in a rural setup, the most common assault is because of firearms, but in urban, it's still a fist injury, physical direct harm. Now, what are the first steps that you'll need to take? Even if you're dealing with polytrauma, you have to stabilize the vitals. There are two landmark cases in the Supreme Court. One is called the Parmanand Katara, which makes it mandatory for all doctors, irrespective of their specialties, to take care of emergencies. And the second one is called the Good Samaritan case, where you are absolved of liability if you have taken care of the case, did not know what to do after that as a specialist, and referred it to a higher center. So these two become both your duty and your responsibility as healthcare professionals. Of course, if it's only ocular related trauma, the buck stops with you and it's not a case of polytrauma. So now, who can make the medical legal case? You should not assume that it has to be done by a government hospital or a government doctor. Private doctors not only can make it, they should make it. And if you are the second doctor seeing this patient after some colleague has referred it to you, you will have to make a fresh MLC. Remember this is still mandated by law. And you must inform the police in case of a medical legal case, and medical legal cases have to be made even if the patient or relatives say, I don't want to make it an MLC. This is also important. Irrespective of what your hospital protocols are, this is what is accepted in law. And failure to do so is a violation of IPC 201. Writing this in your record of an accident register as alleged history, because it's not proven till it's proven. And store the medical records as per the law. Currently, it's either 3 years or 7 years. We'll talk about what kind of data there is. And then you must have access to the close by ambulances and emergencies if you are transporting such a polytrauma case. Next, how will you be deposing before law? You can depose either as an expert for opinion, that is either your case or somebody else's case, or the law says that you come here and tell us how much compensation has to be paid for this injury case. So these are the kind of reasons why you might be called by court of law, either as the first doctor, treating doctor, expert opinion, or to calculate the negligence. Now, civil matters and criminal matters, they are equally important. Criminal matters, there are two, that is injury during assault, of course, a fight on the road, or trauma during workplace. And these two are slightly different for us to know, so let's talk about that. Now, when would you require to give a trauma or a wound certificate? These are the 4 conditions, either under the Employee Compensation Act, that is obviously workplace trauma, or if somebody is filing insurance reimbursement, or under the Consumer Protection Act, if somebody has filed a case against the primary doctor, maybe against somebody who has hit them, or an accident and so on. And finally, if the court has asked for you to come there, evaluate the patient, and talk about the liability. So trauma by assault, trauma in workplace. Let's deal with these two. Trauma by assault, you have to mention the alleged assault, put that on record, and send the details to the patient and to the hospital, to the police department. Now, what you need to have as a checklist is the medical legal register, the details of every injury, whether it is simple or grievous, and the extent or amount of loss of function. Grievous injury, very big chapter in the section 320. These are 4 that relate to us as ophthalmologists. Permanent loss of eye or vision, permanent disability that can involve the face or the eyelid, fracture or dislocation of a bone or tooth or orbital bones, as Dr. Sumit just showed, and any trauma that can endanger life or put you off doing your normal work for 21 days or more. This is really, really important, the 21 days by law. Now, a checklist for trauma, if you have ordered an investigation, make sure you've preserved those records as well, including the films, and a certificate of injury on demand to be given to the patient if it is a simple injury, but if it's a grievous hurt, as I just showed you, it has to go to the police as well. Record every injury, every investigation, every treatment you've done, record whether it's simple or grievous, and the amount of loss of function. If it is grievous, mention whether it is mechanical, that is injury, assault, whatever, chemical, heat, or electric. Now, workplace. Workplace doesn't differ too much from assault, except for the fact that it will follow the ESI Act. So, extent of loss, find the final loss of function or vision loss or blindness has to be calculated at the end of either the admission period if you have admitted the patient, or the treatment period if you are the treating doctor. So that's the final record. So if you are asked to comment on how much visual loss the patient has, make sure you go back, see when was the patient last seen, whether the treatment was completed. If not, don't give the certificate, say it's pending, call back the patient, reevaluate, reassess, and only then give the certificate. This is roughly the disability. So loss of sight to, goes all the way up to 100%, and loss of one eye could be 40%. These change depending on whether you're looking at NPCB or law, but this is roughly what can be done. Should you take up a case of trauma if you are a general ophthalmologist under the Consumer Protection Act? As I said, you don't have a choice. If a polytrauma patient comes into your clinic, even if you don't have an anesthetist or an emergency, you have to stabilize the vitals, and then only you can refer. Make sure that when you refer, the copy of the letter that says you've referred to XYZ hospital is received, and the patient or the relative signs saying received and the date and time that it is to be done, and store this. It will help you. To summarize, this is the safety checklist. Record the injuries in detail, photos and figures. Do the necessary investigations. Keep the records for 3 years minimum, but ideally they say up to 7. But honestly, as long as you can store it, because if a case goes to court, until the court is deposed, the judgment is made, you may require to hang on to those. Informed consent. If surgery is done, treat the patient as per textbook norms. This is the basic definition of negligence. Refer to a higher center when you can't. Be transparent and polite. Mainly, good communication avoids 99% of medical legal cases. And finally, this legal maxim in Latin says, the ignorance of law is not an excuse. So we must know both our rights and our duties. Thank you.
That was an absolutely excellent presentation, Dr. Anand. Any questions from the audience regarding the 2 talks that we had, or anything before that? So I wanted to ask you something, Dr. Anand. So if there's a patient who's come with a trauma, and at presentation they gave a particular history saying that they fell down or whatever, and that is what is noted and the MLC is made, if it's a workplace injury. But after a day or 2, they come back and they change that history and now say that it was due to someone someone hit them. Should we change what is in the MLC already, or should we leave it? Should we document it somewhere? What is the way we go forward?
Sure. That happens quite often, actually. So in the first case, if it was just a simple hurt and you have just established it in your electronic medical records and your hospital records, then sure. Then the first time you actually lodge an MLC register, that's when you can not change it, but that's when you're first documenting it few days later. But if you have actually done the due process of recording it as an MLC case in the first one, then absolutely don't change it, because you've already supplied the information. Your local police has already come and made a record of your MLC case in what they call the daily register. That gets a number, so-and-so / so-and-so, so-and-so. And that will be produced in court as evidence. And if you then change it, it will be as though you are violating that evidence, and the onus will fall on you. So don't.
The patient is now changing history in the EMR,
sure,
or your
that
record?
would be in your hospital records, but not in the medical legal records. That can be added as a separate affidavit saying that this happened, 4 days later this happened, but the original record stays as the original record.
Remains the same, yes. Yeah. Our next presenter is Dr. Anusha Arvind. She's a consultant at Narayan Nethralaya in the Department of Neuro-Ophthalmology, and she'll be talking to us about another very severe and important injury of traumatic optic neuropathy. While Dr. Anusha is setting up, one question for Dr. Sumit. If we have a patient who we are suspecting an orbital injury, okay, is your go-to mode of evaluation always a CT scan, or is X-ray still adequate? Because sometimes they'll say that they may not have money or anything. Is that adequate, or would you always insist on a CT, or how do you go about it?
No, ma'am. The X-ray is the first mode of investigation always, since we need to rule out also foreign bodies here, because even a first case that I showed, a preseptal cellulitis, can have a foreign body behind.
Yes.
So doing X-ray always makes a sense. But in case you see the post-septal part is involved, there is a proptosis, there is a deficit movement, then you will insist for doing a CT scan for sure, even after X-ray.
And is there any difference in your management or time of management, being it a pediatric or an adult case? Does that have any bearing?
Yes, ma'am. But like I showed, the pediatric generally present little later. But if once I see, then it becomes an emergency because there is a trapdoor
Yes.
either, or patient has a bradycardia and they are not able to complain about all that. Then of course the pediatric becomes very much emergency in such cases.
Right. Thank you. Over to you,